Radiography in dentistry. Radiography is the art and science of using radiation to provide images of the tissues, organs, bones, and vessels that comprise the human's body. Treatment of a patient depends on the accurate and precise production of radiographic images. The interpretation of dental radiographs is similar to the systematic approach that we employ with standard radiography in our general practice. Objectives. The students should know the normal anatomy of the tooth under dental radiograph. The student should interpret the pathology of the tooth under dental radiograph. Let's begin from terms. As for me, it is the best source, the free medical dictionary, and according to this dictionary, dental radiograph. It is a radiograph on dental structures made on X-ray film or stored as a digital image. The radiographs may be extraoral or intraoral. Three common types of intraoral dental images are periapical, interproximal, and occlusal radiographs. Moreover, dental radiography, it is the art of producing an image or picture for intraoral or extraoral structures on a dental film or sensor using X-rays. Classification of dental radiography. As I told earlier, all dental radiograph are divided into intraoral and extraoral. But every this X-ray are divided into periapical, between, and occlusal. But extraoral X-rays are divided into panoramic X-ray or orthopantomography, cephalometry, but cephalometric X-rays are divided into lateral and frontal, and cyalography. Let's talk in details about every type of dental X-rays. First one is intraoral periapical X-ray. It is the most frequently used intraoral view radiograph, which shows the entire tooth and surrounding structures of the film or screen. And need for prescribing periapical dental radiograph. Extent of caries involvement in the tooth. As can you see, the caries lesions, decay of teeth, and I am sure that these tooth and these tooth have not only caries but pulpitis too. Why? Because caries cavity are connected with pulp chamber here. And the same situation here. Or another situation, when wrong positioned wisdom tooth caused caries in second molar. Doctor sometimes cannot notice these caries during intraoral evaluation. But as can you see, doctor can find it very easy in intraoral periapical radiography. Moreover, the caries in the opposite side. This radiograph is very interesting. Why? Because we can observe strange shape of pulp chamber instead of not caries next tooth. Why? You can see obliteration of pulp chamber by secondary dentine. Pulp chamber was here, but in reason of chronic caries, human's organism created secondary dentine to separate infection from pulp. Interproximal decay under the contact point. Please, colleagues, be very attentive. These kinds of caries is not visible intraorally, but we need to pay attention by interproximally surfaces to notice it in time. Next situation, multiple interproximal decay. Another reason to do periapical pathological changes, periapical dental X-rays, look for some periapical pathological changes. As can you see, patient has big periapical cyst. Reason of it, not satisfied treated mesial channels in tooth number 3-7. Another X-ray. It is typical cyst with clear visible borders. Another periapical change. It is cyst 2. In this cyst are involved apices of 2 teeth, tooth number 2-1 and tooth number 2-2. But this tooth was endodontically not treated previously. Maybe it is complication of deep caries treatment, and as a result was developed pulpitis, and next stage, periodontitis and cyst. Traumatic injuries to dental alveolar process. They are shown a fracture of coronal part of the tooth number 2-1. They are clear visible fracture of coronal part and not so clear fracture of root. Another X-ray, fractures in middle part of roots, teeth number 1-1-1. Another example, fracture of middle part of the root, tooth number 1-1. Different periodontal diseases, like here, we can observe low level of alveolar bone and resorption of the bone between roots in the tooth number 4-6. As can you see, a low level of bone and resorption. Next indications, dental anomalies, like this, ingrown teeth, or here, double tooth, or here, ingrown two teeth. Hidden diseases, like internal resorption. You can see, we can observe resorption of dentine, and we cannot find it without X-rays. Or another pathological situation, internal resorption too. Prognostic assessment during treatment planning. For this purpose, we need to have many periapical dental radiographs and complete with a special chart to observe every tooth. Post-obturation assessment of endodontic therapy. They are shown a very interesting situation. Left lower second premolar with successful filled 1, 2, 3, 4, 5, 6 root canals. Of course, this work was done under microscope. You cannot have this treatment only manually. Moreover, I think it is a specific patient because previously tooth has 1, 2, 3 root canals minimum. Like next tooth, 1 root canal is divided into 2 root canals. Or another situation, upper right first premolar, tooth number 1, 4, with 1, 2, 3 root canals. Or tooth number 1, 5, upper right second premolar, with 2 apices. You can ask me, what does it mean, this white line? I think it is fistula, and filling material was passed through fistula, or maybe additional root canals. I'm not sure. Working length measurement during root canal therapy. As can you see, doctor put into every root canals files and made X-ray with that files, and length of every file must be measured and noticed for future steps of endodontic treatment. And of course, in case of implants, we need to evaluate peri-implant bone, and we need to evaluate bone in area of neck of implant, to be sure that there are no present some inflammation or some cementum from implant. The radiographic recognition of disease requires a sound knowledge of the radiographic appearance of normal structures. As can you see, doctors, radiologists like jokes too. Let's begin from cornerstones. First, some definitions. In radiography, there are two main terms. Radio-opaque, it is white or gray areas. White or gray areas on X-rays, it is metal or enamel or dentine or bone. Or zirconium. Zirconium is white like metal. And radiolucency. Radio-opaque and radiolucency. It is black areas, less gray than neighboring area, like here or here. What findings in radiographs we need to evaluate? Hard tissues such as bones and teeth, radio-opaque view. Teeth, bone, radio-opaque. Anatomic landmarks, foramens, cavities, radiolucent. For example, pulp chamber, root canals are radiolucent. As can you see, radio-opaque bone teeth, and radiolucent. Canalis mandibularis, foramen mentale, roots and pulp chambers. Moreover, radiolucency have nasal cavity and different sinuses, like this sinus, bone ridges has a radio-opaque view. Bone ridges, like this one. Why? Because bone is more thick. More thin. No, thick. More thick. Like here. It is anatomical structure, external oblique line. Cysts, bone lesion visible as cavity. Radiolucency. They are cyst from impacted tooth number 3-8. In this cyst are involved distal root of tooth number 3-7, and distal root of tooth number 3-7 is resorbed. Metal ceramic crowns looks like here, or zirconium or metal crowns looks like here. But plastic or non-metal ceramics looks like here. Let's talk about normal periapical radiographic anatomy. On periapical X-ray, we need to understand that the enamel, E letter, dentine, D, main tissue of every tooth is dentine. Pulp cavity, PC. Root canal. Amelocemental junction. It is area where enamel is connected with cementum. Amelocemental junction. Periodontal ligament. It is small space between root and bone. And lamina dura. It is white line outside of periodontal ligament. It is internal side of alveolar. Enamel, the most radio-opaque structure. Dentine, slightly lighter than enamel. Pulp cavity. Radiolucent lines within the tooth. Alveolar crest. Gingival margin of the alveolar process appear as a radio-opaque line. periodontal ligament space narrow, radiolucent line around tooth surface, lamina dura, radio-opaque line representing tooth socket. Step by step, analytical process that provides an exact idea of the clinical problem and helps to achieve the final diagnosis of any particular lesion. Radiographic interpretation is an essential part of the diagnostic process. The ability to evaluate and recognize what is revealed by a radiograph enables us to detect diseases, lesions, and conditions which can be identified clinically. And according interpretation, I would advise you mention this abbreviation. Remember this abbreviation, logic. What does it mean? L. Localization. O. Observation. G. General consideration. I. Interpretation. C. Correlation. During our interpretation of X-ray, we need to describe every this position. Localization. We need to describe, is this problem localized or generalized position in the jaw, single or multiple, and size of this pathology. Observation. All shadows other than the localized shadows of the normal landmarks must be observed. For example, shadows in crowns, cervical area, roots, restorations, size of root canals, periodontal membrane space, periapical area, alveolar crest, foreign bodies, integrity of bone. General consideration. A radiograph shows only two dimensions of a three-dimensional object, width and height, but not the depth. Cervical burnout usually appears as cervical radiolucency and misinterpreted by caries. This occurs due to less density and more penetration of rays. Pulp exposure, never to be determined from radiograph but only the proximity to the pulp. Interpretation. Studying the features of the teeth and bone. Teeth. Study the whole tooth, crown, root, enamel, pulp, number of teeth, and finally supporting structures. Periodontal membrane space, lamina dura, alveolar crest. Bone. Changes in bone may include changes in density, changes in the margin, changes inside the lesion, effect on surrounding tissues, changes in structure. And last characteristic, correlation. The final step is to correlate all of the radiographic features to reach a radiographic differential diagnosis. Then, to draw a final diagnosis, we have to correlate other data as case history, clinical examination, and other diagnostic aids with the radiographic differential diagnosis. Once again, doctors, intraoral radiography, it is only two-dimension. What does it mean? It means that we three-dimension object looking like two-dimension imaging. It is so nice showed in this part of cinema.
Austin, what's our plan?
According to this map, the entire island is crawling with Dr. Evil's guards.
I want to make sure the explosives didn't get wet, but I can't find them.
Look in the bottom.
Okay, I'll dig a little deeper. Wow, this bag is really full.
Just keep digging, darling.
I'll just feel around. Good Lord, Austin. What sort of things do you keep in here?
Anything that catches my fancy, you know? Give it a good tug.
Oh, do we really need this?
I'll ask you not to open that inside, thank you very much.
Sorry.
Okay.
Oops, it went off.
Yes. It does that from time to time. Yes.
Yuck.
Yeah, that's nasty. Yeah, sorry about that.
Smelly.
These people make me sick.
Can you snap me a beer? What is it?
It's a gerbil. How did that get in your bag?
I don't know.
Got this packed really tight. Are you okay?
Yeah, I just got a bit of a back cramp, that's all. Just keep packing it in.
I found the explosives. Help me check them.
You're surrounded! Drop your weapons! Hands up! Move out! Come on, hurry! The map! Okay, what's our plan?
I'm going to need a urine sample.
Which way to the main chamber?
Excuse me, Doctor.
It's difficult in public, isn't it?
Minnie, our shadows! We're casting a shadow!
What's wrong, sailor?
You should check that guy out.
What the hell's going on here? Hands up! You heard me, I said hands up. Both of you. Come with me.
Minnie, the map, go!
Okay, you got me.
I hope, doctors, you understand that these letters are not inside of body of this boy. Yeah? But as for me, it is so original proposition to marry. Interpretation. What we can find in animal. Caries of animal appears at the radiolucent area. Radiolucent area. Animal hypoplasia appears as a radiolucent area surrounded with radio-opaque margin. Amelogenesis imperfecta. All the animal appear as a radiolucent area. Moreover, a wrong shape of crown parts, not typical shape of crowns. Let's go deeper. Dentine. Caries of dentine appears as a radiolucent area. Dentinogenesis imperfecta. Dentine appear as a radiolucent area surrounded by faint radio-opaque margin. It is systemic disease. Dens in dente appears as a radio-opaque structure within the tooth surrounded by radiolucent margin. Internal resorption. Radiolucent lines on the apex or lateral side of the root dentine. Pulp. Let's go deeper. At first we described animal, then dentine, then and now pulp. Calcification of the pulp appears as a localized area of radiopacity. If the calcification is generalized, it appears as a generalized area of radiopacity. Not so widespread situation like shell tooth appear as a white pulp chamber, like a wide pulp chamber. Let's go deeper. Cementum. Hypercementosis appear as a radio-opaque area covers the cementum line. Cementoma appears at the apex of tooth as a radiolucent area in its early stages and converted into radio-opaque at the terminal stages. Periodontum ligament space normally appear as radiolucent lines around the root surface. Widening of the space as a result of osteolytic process. Example criteria: osteolytic osteoma. Narrowing of the space as a result of osteoblastic process. For example, scleroderma. They are shown a widened periodontal ligament space or narrow periodontal ligament space. Lamina dura normally appear as radio-opaque clear continuous band, covers the alveolar bone, for example, lining the socket, and covers the crest of the alveolar bone. Discontinuity of the lamina dura indicate pathological changes. Lamina dura must be continuum, white line. But loss of lamina dura looks like here. Alveolar bone. Bone resorption either horizontal or vertical. Bone loss can be alveolar bone height, alveolar bone health, and generalized versus localized alveolar bone loss. Left picture, they are shown horizontal bone loss. A reason can be inflammation like parodontitis. But on the right picture, they are shown vertical bone loss. Reason of this situation can be overloading of this tooth, over contact, and chronic occlusal trauma. Metallic restoration. Restoration done on tooth showing radio opacity. Status of root filling, root canal treatment. Radio opacity on the whole pulp chamber can be seen. Instead of a left picture, as can you see, root canals are not treated satisfied, and it caused development of periapical cyst. Dental implant. What we need to evaluate in case of dental implant? Dental implant shows obvious shape and radio opacity on radiographs. Next purpose of periapical radiograph in X-rays, it is follow up. We can observe treatment process before root canal treatment and after root canal treatment, or results of our treatment, some granulomas or cysts. As can you see, after successful endodontical treatment, we can observe restoration of bone. And now about extraoral X-rays. What is the purpose of extraoral imaging? Examine large areas of the dental arches and skull. Study growth and development of the bone and teeth. Detect fractures and evaluate trauma. Detect pathological lesions and diseases of the jaw. Detect and evaluate impacted teeth. Evaluate temporomandibular joint disorders. Plan treatment for dental implants and prosthetic appliances. But what are other reasons for extraoral radiography? Limited mouth opening. When it is impossible to put film or sensor inside of oral cavity, we can use extraoral X-ray. Lack of patient compliance for intraoral films. For example, high vomiting reaction. Disabled patients who cannot cooperate or are physically incapable of managing intraoral films. Patients with trismus or TMJ disorder. And specialty needs. What do orthodontists use extraoral radiographs for? Orthodontists use extraoral radiographs for comparison and measurement of growth and development, especially with iPhone. What do prosthodontists use extraoral radiographs for? Prosthodontists use extraoral radiographs for facial profiles. Facial profiles are recorded to assist with reproducing contours of the face and the relationship of the teeth. What do oral surgeons use extraoral radiographs for? Oral surgeons use extraoral radiographs to evaluate of trauma, fractures, impacted teeth, lesions, and temporomandibular joint disorders. And now, in detail, about orthopantomography. OPG radiographs. It is an extraoral technique which produces a radiograph with wide view of the maxilla and mandible. It's also known like pantomography or rotational panoramic radiography. Panoramic radiography, also called panoramic X-ray, is a two-dimensional dental X-ray examination that captures the entire mouth in a single image, including the teeth, upper and lower jaws, surrounding structures and tissues. Indications for panoramic X-ray: gross or multiple caries, pain related to a whole quadrant, orthodontic assessment, preoperative assessment, mandibular fractures, cysts, tumors, developmental anomalies, assessment of temporomandibular joint, periodontal disease, impacted tooth, implants. They are shown what we will see on panoramic X-ray. It is our skull, a volume object, 3D object in 2D imaging. Now about normal radiographic anatomy on panoramic X-ray. The bony anatomy seen on OPG includes the bones of the mandible, maxilla, zygoma, and temporal bones. On mandibular we can observe condyle process, neck, coronoid notch, coronoid process, ramus of mandibular, angle of mandibular, body of mandibular, symphysis menti, mental foramen, and mandibular canal. Of course, level of alveolar bone. Next bony anatomy seen on OPG includes the bones of the mandibular, maxilla, zygoma, temporal bones. Maxilla, orbital floor. This white line is hard palate, nasal wall, nasal septum, intermaxillary suture, alveolar bone, maxillary sinus and maxillary sinus wall, glenoid fossa, zygomatic arc, and styloid process, processus styloidus. The soft tissue anatomy includes the superficial facial structures, the soft palate, pharynx, tongue, and nasal passages. They are visible: pinna, soft palate on right and left halves, inferior turbinate, epiglottis. What is this, doctors? You are right. It is sublingual bone. Moreover, we can evaluate air cavities on OPG. The air cavities are demarcated by the soft tissues and bones. These include the pharynx, nasopharynx, oropharynx, hypopharynx, nasal cavity, oral cavity. Oral cavity is not all this area. All this area are filled by tongue, but oral cavity is above tongue, and of course larynx. On this slide, schematically is showed all that structures. Please look attentively. They are schematically shown all that structures. Interpretations of OPG. Describing the lesion. Every lesion must be described with size, shape, location, density, borders, internal architecture, effect on adjacent structure. First one, we need to describe what dentitional status, Nola stages. Panoramic radiograph shows unerupted tooth and help to diagnose Nola stage and dentitional status. For example, when you will describe OPG like this, you need to tell that it is panoramic X-ray of child in stage of variable or changeable dentition, because in oral cavity are erupted permanent teeth and are present temporary teeth, but the observed follicles, germs of permanent teeth not erupted. Please notice, doctors, what pathology we can observe here. Horizontal position of tooth number 1-1. Impacted tooth. Impacted tooth are identified on OPG radiograph easily, as the teeth are displacement and tilted. Symmetrical tooth is not impacted. This tooth is erupted. Instead of it has a wrong position, but it is erupted. But tooth number 1, 3 is not erupted. It means that it is impacted. Fractures. Bone displacement, broken mandible gives the diagnosis of fracture. Tumors, lesions. Ill-defined borders with sclerosis and ground glass appearance gives the diagnosis of lesion. Cysts. Presence of radiolucency, cortical borders, locularity and displacement of tooth shows the diagnosis. Calcifications are also important, as they can indicate the position of many structures, including the submandibular duct, the palatine tonsils, and the carotid arteries. They are shown calculus inside submandibular gland or carotid artery calcification. Calcification of arteria carotis. Interpretations.
The interpretation of a panoramic radiograph follows the same principles as in the case of any other film or film series. A systematic and repeated process is used to ensure that all significant findings are identified. First, the osseous structures and surrounding soft tissues are assessed. Second, the alveolar processes are examined. And finally, the teeth are evaluated. Compared to a series of intraoral radiographs, the panoramic radiograph depicts a much larger area of anatomic structures of the oral and maxillofacial region. Therefore, much more time will be spent doing this part of the interpretation. It is critical to have a good understanding of the normal anatomy in order to identify the presence of any abnormalities. It is useful to compare the left and right sides of the image when deciding if a finding is normal, since structures appearing bilaterally are generally anatomic. Comparing the left and right sides should also be done in order to detect any asymmetries that may be indicative of pathology or a developmental condition. Begin by assessing the periphery and corners of the image. This is a good habit because often observers are too occupied with looking at the center of the image, zoning in on the teeth and jaws, and the outer edges of the film are neglected. In these areas, the orbits and the skull base, including the articular process of the temporal bone, are assessed, and the contents of the neck, including the pharynx and hyoid bones, are seen. The cervical spine, styloid processes, and any calcifications in submandibular glands may also be present, but are not captured in this image. Next, examine the outer cortices of the mandible. Abnormalities could include discontinuities or missing structures. Begin at the base of the anterior surface of the ramus on the right side and trace up and around the right coronoid process, down the coronoid notch, and around the condylar head. Examine the posterior border of the right side of the mandible, around the angle and along the inferior border to the left side. Continue around the angle of the left side of the mandible, up the posterior border, around the condyle, coronoid notch and coronoid process, and down the anterior border of the ramus on that side. Now move to the maxilla and examine its cortices. Begin at the most superior aspect of the posterior wall of the right maxillary sinus and assess this cortex as well as its floor and medial walls. Repeat this process for the left side. When examining the posterior border of the sinus, It is important to also identify
examining
the
the posterior
zygomatic
border of
process
the
of the
sinus,
maxilla
it is
and the
important to also
pterygomaxillary
identify
fissure.
the zygomatic process
These
of the
structures
maxilla
produce thin
and the
radiopaque lines
pterygomaxillary
that run
fissure.
roughly parallel to the
These
posterior
structures
wall
produce
of the
thin
maxillary
radiopaque
sinus
lines
and may
that
be
run roughly
confused with it.
parallel to the posterior
Follow
wall
the
of
left
the
and
maxillary
right
sinus
zygomatic bones
and may
and
be
arches
confused with it.
as they extend
Follow the
posteriorly
left and right
from the
zygomatic
zygomatic
bones
processes
arches
to the temporal
as they
bones.
extend posteriorly
Finally,
from the
look at
zygomatic
the internal
processes
density
to
of
the
the
temporal
sinuses,
bones.
comparing the left
Finally,
and right
look
sides.
at the internal density of the sinuses.
Assess the structures
comparing the
of
left
nasal
and right
cavity,
sides.
including the floor and concha,
Assess the
which extend
structures of
horizontally
nasal cavity,
along both sides of
including
the
the floor
image,
and concha,
and the nasal
which
septum.
extend horizontally
Note the
along
soft
both
palate,
sides of the image,
imaged
and the
bilaterally
nasal
as it
septum.
extends off the
Note the
posterior
soft palate,
aspect of the hard
imaged
palate.
bilaterally as it extends off the
Now
posterior
examine the
aspect
bone
of the
pattern
hard
of the
palate.
maxilla and mandible.
Now
Assess the
examine
density
bone
and pattern
of
of
the maxilla
trabeculi
and
for any
mandible.
abnormalities.
Assess the
Comparing
density
left and right
pattern of
sides is
trabeculi
useful,
for
but
any
keep in mind
abnormalities.
that some conditions may
Comparing
present
left and
with a
right sides is
generalized
useful,
alteration in
but
bone
keep in
pattern.
mind that some conditions
In the
may
mandible,
present with a
look at the
generalized
left and right
alteration in bone
inferior
pattern.
alveolar nerve
In the
canals
mandible,
and the mandibular
look at the
and
left
mental
and right
foramina.
inferior alveolar
Examine their
nerve
size,
canals
position,
and the mandibular
cortication,
and mental
and
foramina.
symmetry.
Examine their size, position,
Next,
cortication,
the alveolar
and
process
symmetry.
and teeth are evaluated. The spatial
Next,
resolution of
the alveolar
panoramic
process
radiographs
and teeth
is
are
much lower
evaluated.
than intraoral
The spatial
radiographs,
resolution of
making
panoramic
assessment of the
radiographs
alveolar
is
process
much lower
and
than
teeth
intraoral
more difficult.
radiographs, making
Nonetheless,
assessment of the
any
alveolar
visible
process
positive
and
findings
teeth more
must be
difficult.
identified.
Nonetheless,
These structures
any visible
should be viewed
positive
in a
findings
systematic
must be
manner,
identified.
examining the posterior
These
of the
structures
first
should be
quadrant
viewed
to
in
the
a
posterior
systematic
of the
manner,
fourth quadrant
examining
in a
the
clockwise
posterior of the
direction
first quadrant
around the
to the
arches.
posterior of the
This
fourth
sequence
quadrant
is followed
in a
for each
clockwise
possible
direction
finding.
around the arches.
Begin examining
This
the
sequence is
alveolar
followed
process
for each
by
possible
assessing the
finding.
crestal bone position
Begin
and
examining the
identifying
alveolar
any
process
periodontal
by
bone loss,
assessing the crestal
including
bone
horizontal,
position and
vertical,
identifying
and
any
furcation
periodontal bone
defects.
loss, including horizontal, vertical, and
Next,
furcation
look for
defects.
signs of inflammatory diseases, such as rarefying osteitis
Next,
and
look for signs of
sclerosing
inflammatory
osteitis.
diseases, such as
Examine
rarefying
the periodontal
osteitis
ligament
and
spaces
sclerosing
and lamina
osteitis.
duras for anything affecting
Examine the
their
periodontal
continuity.
ligament spaces and lamina duras for anything affecting their
The
continuity.
features related to teeth that must be reported are discussed in more detail in other
features related
resources.
to teeth that
However,
must be
be
reported
reminded to
are discussed in
identify
more
any
detail
visible
in other
caries,
resources.
inadequate
However, be
restorations,
reminded to
calculus,
identify
and
any
any
visible
eruptive,
caries,
developmental,
inadequate
and acquired
restorations,
abnormalities.
calculus, and any eruptive, developmental, and acquired abnormalities.
It was short summarizing of previously information. Extraoral cephalometry. What information we can get from evaluation of cephalometric X-rays? Facial growth and development, trauma, disease and developmental abnormalities. Lateral cephalometry. Orthodontics aims cephalometric analysis, facial growth and development, disease and developmental abnormalities. Orthodontists use describing evaluation of cephalometric lateral and frontal cephalometric X-rays to make diagnosis, to plan treatment, to control duration and final results of treatment. Moreover, lateral cephalometric X-rays we can use for airway evaluation. And a frontal cephalometric X-ray are used for facial growth and development evaluation, disease and developmental abnormalities. And cealography. What is it? Cealography is the radiographic examination of the salivary glands. It usually involves the injection of a small amount of contrast medium into the salivary duct of a single gland, followed by routine X-ray projections. The resulting diagram is called a cyelogram. They are shown submandibular salivary gland cyelography. And modern X-ray technologies, it is 3D technologies. What are 3D technologies? 3D technology, it is evaluation different areas of human's body, different organs in 3-dimensional. "3D", it means 3-dimensional. And what kind of 3D methods we can use in dentistry and in medicine at all? Tomography. What is this tomography? It is simultaneous movement of the X-ray source and the image receptor to image structures within a selected plane of tissue. But nowadays in medicine are present CBCT, cone beam CT. What differences between CT scan and cone beam CT? And advantages. Cone beam CT is a variation on traditional computed tomography CT that is on the rise. Unlike traditional CT scanners, in cone beam CT, an X-ray tube and detector panel rotate around the patient, capturing data with a cone-shaped X-ray beam instead of the slice CT scanners are typically known for. At this table, I would like to show you differences between traditional CT and cone beam CT. Advantages and disadvantages. According to type of X-ray tube, traditional CT has high output rotating anode X-ray tube, but cone beam CT, like source of X-ray, has low power medical fluoroscopy tube that provides continuous imaging throughout the scan. Differences are between types of sensor. Traditional CT records data with a fan-shaped X-ray beam onto image detectors arranged in an arc around the patient, producing a single slice image per scan. Each slice must overlap slightly in order to properly reconstruct the images. Instead of cone beam CT, uses a cone-shaped X-ray beam that transmits onto a solid-state area sensor for image capture, producing the complete volume image in a single rotation. And of course, radiation dose. Traditional CT has more time and of course, as a result, more dose. But cone beam CT image capture used in cone beam tomography is quicker than traditional spiral motion and can be accomplished at a lower radiation dose as a result of no overlap of slices. I would like to show you my patient, to show you differences between information what we get from 2D X-ray or 3D. Complaints: pain in temporomandibular joints. What can we observe on panoramic X-ray from TMJ? As can you see, the different shape of TMJs. A right one has typical shape instead of left one has untypical this area, flat area. But when we observed CT, we found many interesting, like these cavities and strange structure. Strange structure of condyles. I will show you how must looks normal condyle in horizontal view, horizontal section, and condyle of this patient with strange elements. Frontal view, coronal plane. Normal frontal view, condyle. Similar structure, clear borders. Instead of not similar structure and not clear borders. And sagittal view. Normal condyle, wide border, and abnormal condyle with that elements. This situation called subchondroidal cyst. Subchondroidal cysts.